So now we will move into the next session of very exciting, exotic cases to be presented by the masters, and that's what we've been waiting. So one of the masters is missing. Maybe let me invite as experts Pradeep Yadav. Pradeep is already here with us. Dr. Z.S. Meherwal, Dr. Maulik Parekh, Dr. Amit Chaurasia, Dr. Vijay Trehan, Eberhard would stay with us, Dr. Rajiv Rathi, Dr. R.D. Yadav, Dr. Ramesh Raikar, Vineet Malik, Dr. Ritvik Bhuyan, Dr. Geeta Subramaniam, and Dr. Anupam Goyal. Vinay. Please join us, all of you. So I think Horst is making a talk, so we can go with this. Eberhard. Huh? Okay. Can you post Dr. Grube's presentation over here? Yeah.
Yeah. Can I have? Okay, so thank you very much. So I would like to give you a little bit of a heads up of why we did this case and what happened. To be very honest, we never planned to do this case. We had a live transmission, and the live transmission on the primary approach was so successful that we got a little bit over our head and said, well, it went so well, why don't we just keep going? So I'm open for any criticism that you might have, no problem. But I think it is a very important lesson or lecture, if I may say, because it addresses some interesting issues. So here we have a case of a 95-year-old female. Most importantly, she did have a TAVR valve in 2012, a CoreValve Classic at that time, and the scores are high, as you can see, and we needed to do something about it. So this is basically the initial image of the aortic valve, and I would like to point out a few things that are important for treating valve-in-valve patients in the aortic space. Most importantly, I mean, here you can see basically the gradients and the hemodynamics, but importantly is the case planning, as the previous speakers have pointed out. Very, very important. Think about it, take your time. What is the best approach to correct this? What I would like to show you here, I don't know, here it is. Here there's a little star. Usually degenerations start at the base of the leaflets. And here you can see, can we move this again? It doesn't move. Can you play this again? Yeah, perfect. Here you can see, this is the stiff part, very important, and you will see why that is. It's not the tip of the leaflets, it's the base where it starts. And here basically the same thing, no question, it is aortic stenosis with a lot of, flow pattern of turbulence. And here you can see basically the workup. Most importantly, where are the coronaries? How does the sinus of Valsalva, and where are the leaflets? So these are the regular measurements. We can go over this a little bit faster, and here you can probably see the axis was not a big problem in this particular lady. In addition, she had severe mitral regurgitation. I don't want to go into the details. You can read all the hemodynamics there. But it was mixed etiology, both degenerative and functional, and she had massive tricuspid regurgitation. Can you let this run again, please? Okay, it does, it's too bad it doesn't run on, okay. Anyway, it is massive. I hope you believe me. But If not, then, so what we wanted, are you trying or? I think we can continue. Believe me, it was massive tricuspid. I hope we can see it later on. So basically here we can see a valve-in-valve TAVI with a SAPIEN 3 23 millimeters. And as you know, a previously implanted core valve, if you try to do a second core valve or a second self-expanding valve, that's off-label. So we decided on the SAPIEN 3 23 millimeters, and I will show you in a minute why it's just important. Mitral clip for the MR and tri-clip for the TR. You can see all the important information, but I hope you believe me, it was indicated. If we don't have, can we let it run? Okay, so nothing. I don't have control of the mouse here. It doesn't run either. If we don't have the videos running, then I think we should skip and I use my computer, because the most fun is when you see the images.
Yeah. Yeah, so we'll switch to the laptop. Yeah.
Atul, can we, till the time they are doing, can we discuss about a 95-year-old person?
Okay.
Yeah.
So here we go again.
Sorry.
Here you can see, again, please look at the base of the aortic valve. This is an important detail. This is the workup. And here you can see the leaflets, peripheral axis. And here you see the mitral, and here you can see its tricuspid regurgitation, which really is significant, as you can imagine. So it's a valve-in-valve with SAPIEN S3, mitral clip, and tri-clip. Multivalvular disease, aortic stenosis, degenerated bioprosthesis, core valve, mitral, and tricuspid in a 95-year-old. Again, here you can see the flow pattern. It is clear. This is a core valve, degenerated core valve, and I think you all agree in this 95-year-old, you don't go to surgery. You try to do a valve-in-valve. And we use the S3. We see the peak-to-peak gradient, which was 62. And then we decided, because what you saw was that the coronary took off at 11 millimeters. So when it's above around 10, then you should raise your flag, the red flag. Should we or should we not? Anyway, we decided to protect the coronaries, and when we protect the coronaries in the 95-year-old, we place the stent. We don't put the wire down and then put the stent in afterwards. We just place the stent in case we need it. It's going to be done quickly. I'm not sure whether we need to go this. This is pretty straightforward on how you do this. But the positioning of the core of the SAPIEN 3 is really very important. You have to know where you place the valve, and on this core valve, we did on the workup. We decided to put the inflow over inflow. This is usually where you put your SAPIEN, your balloon expandable valve. If you go higher, you might be able to clip the leaflets against the frame, but we don't need it. Even if there's a little bit of overhang of the leaflet, of the original leaflets, it doesn't matter. Most important, obviously, to go all the way down into the inflow of the previously implanted core valve. So inflow over inflow, that's the most important part. And then comes, before I show you the next one, you will see when you deploy the valve, when you deploy the sapien, because of the basal calcifications, the sapien tends to move up. If you don't know this, and if you're not prepared, the valve slips up because the calcification pushes the valve up as the valve is being deployed. And you can see that if you watch the next video, how much we push the valve down by looking at the outer curvature of the aorta, how much push we do. And this is, you can see the protection, and this is how we do the valve. Look at it, and look at the catheter here, how we push the valve down. If we hadn't done this, then the valve would have slipped up, and you wouldn't be inflow over inflow, plus you would be, even though it's a sapien, you would probably be okay with the coronary access, but there's always a danger that it slips further up. So this is a very, very important point when you do the valve preparation for valve-in-valve S3 in a core valve. And you can see how the delivery catheter is being pushed down in order to keep the valve there. Well, then it's pretty much routine now. You check for the peak-to-peak gradient, which is good. Functional valve assessment is all good. Sapien sits well, no leak. The root shot is giving you also a good result, and the coronaries are free, and there's no problem. Then mitral clip, and you've seen this before. The G4 for severe MR, the mixed etiology. You can see A2P2 grasping of the generation 4. As we move on, we were happy that the core valve, the valve-in-valve went well. We had enough time for the live transmission, so we moved on to the clip, and we reduced the clip. Here you can see it was a reduction to mild, which was acceptable in a 95-year-old, obviously. Mean pressure gradient 4, which is also acceptable. Then we went to the tricuspid. You remember it was massive TR, generation 4 XTW, the anteroceptor commissures. That's usually where we start, and Dr. Yadav has shown this before. This is actually the most important clip position. We reduced it, but weren't really happy. Plus, we still had some time. We did another one, a second one in the anteroceptor commissure, another clip, and then we reduced that one. The mean pressure reduction to our mild, as you can see here. So it's a very nice and very acceptable result. Mean pressure gradient of 2.5 on the tricuspid. So basically, the future is now. I think that's what we can do if we are lucky, if you're experienced, and if you feel confident that you can do it. A not maybe very complex valve-in-valve procedure if you do the right planning. And then you keep going. If you're experienced in mitral clip and tri-clip, then you can do what we have done here. And the triple valve intervention, and the patient here, you can see the 95-year-old. She's really, really happy. Now she can walk again, and I think we did well with this triple valve procedure, but I think I just wanted to show you a little bit of this fun, and this is the nice things that we can do in interventional cardiology, particularly in the elderly, who still have the right to live decently, and you can see she's a very, very happy one. Thank you very much.
That's really exotic. Amit?
That was very well explained, Everett. Actually, the position of the valve in valve.
if we position too high, the leaflets are going to get plastered and you may end up closing the corners. But if you are there, then even if the leaflets fall back, then during the diastole, the coronary flow is going to be maintained. I think that is what Dr. Pradeep also wanted to make clear in the previous presentation. Falling back of the leaflet is not going to get problem for the valve because that is happening in the diastole when the coronary flow has to be maintained. It's not going to close. So the positioning should be exactly at the level of the valve.
Yeah, falling back may not be an issue if the leaflets are supple, thin, very easily mobile. In the kind of leaflets which were shown, I think you'll have to draw a balance somewhere. So it may not be totally innocuous to implant inflow to inflow and leaving the overhang. In case it's not there, it is very good. But just in case it is there, maybe you will accept it.
Yeah, I mean, we always remember things that don't go well, that will stick in your mind. And one of the things that I would like to also bring up, apart from the fact that you have to pay attention when you deploy the valve with basic calcifications, to sometimes wire the left ventricle in degenerated valves is not all that easy. Before we knew this, I remember I did a live case and I thought it was a quick one. We got stuck already by wiring the ventricle because the leaflets were tenting as opposed to the native, which are flat. The leaflets are tenting, and they tend to jet, and the wire just didn't go in. Anyway, eventually we did it and we finished the case, but it was very, very difficult. All these things you have to keep in mind when you do a supposedly easy procedure.
And because there is a small concern, that's why you are keeping stents in the left vein.
I'm sorry?
Because there is still some concern that leaflets may not fall back in diastole. That's why we are keeping a protection for the coronary.
Yeah, that's the other danger, obviously.
To be doubly sure, you want to leave some.
Too much, and then you have a big problem. But since this didn't happen, we felt comfortable to move on and do the clips.
The second thing is we always have been telling that the difficulty of coronary cannulation with the core valve. You can see the master. He has cannulated it before the procedure, after valve in valve, and shown that the coronaries are well flowing. So it's all about practice. You can do it with the core valve. You can do it with even Sapien. There is no problem with balloon expandable or a self-expandable. It all depends upon your practice.
Thank you. So over to Horst for.
Thank you very much. You hear me? Yeah. So title of this case presentation is Neo-Cause Case when SUR. Just move this forward. So this case again involves a stroke, and so another good opportunity to make you aware of this stroke conference in September in Frankfurt. This case presentation is not only about NeoCord, it is also about decision making, heart team, brain team, responsibility, stroke in the Cath Lab, and turf battles. You don't have this in India, but we have this in Europe. So a stroke in the Cath Lab is our most serious complications, beside death, of course. Can happen and has happened during all kinds of interventions: carotid stenting, TAVR, LAA closure, PCI, PTA, and any other peripheral structural or vascular intervention. In ischemic stroke, dead tissue is surrounded by a so-called penumbra, and that means ischemic brain cells within the penumbra may be saved from infarction by early treatment. And here, time is brain. If you act fast, then you can solve the problem. And breakthrough in this technology has been Stent Retrievers, where we go into the clot with a microcatheter, microwire, then we insert these stent-like devices, Stent Retrievers. We pull them back when the thrombus is embedded into the stent retriever and pull them out from the brain. The conventional management of acute stroke in the Cath Lab works like this. You are doing a great intervention. All of a sudden you realize that the patient stops talking and cannot move his hand anymore, and you call Dr. Neuro. Dr. Neuro arrives in the Cath Lab, and Dr. Neuro tells you for a full examination, the patient has to come off the Cath Lab table. So the patient is lifted into his bed for a full neuro examination. And thereafter, the patient is transferred to the CT scanner. Let's hope that the scanner is free and the patient does not have to wait there. And then what does the CT scan show? It shows nothing. Why? Because this is an acute ischemic stroke, and CT is always very early, always negative after stroke onset. Intracranial bleeding is extremely rare during catheter interventions. So CT, per definition, is normal. What happens after CT scan? If Dr. Radio is trained in acute stroke management, he will perform a CT angiogram. This may or may not show a large vessel occlusion, but if Dr. Radio is not trained in acute stroke management, the patient will be transferred to the stroke unit according to guidelines for further evaluation and observation and possible treatment. First, an interdisciplinary, multimodal, and multi-competence evaluation and discussion. Thereafter, maybe IV lysis according to current guidelines, but maybe no lysis, because the patient just had an arterial puncture, he just had an intervention, he has received heparin, he may be on aspirin and Plavix, he may have other contraindications for IV lysis. Will lysis be effective if the patient gets it? Well, it depends. If it was a small clot, maybe yes. If it was a large clot, most likely not. The recanalization rate is only 10%. If it was debris, definitely not. And remember, time is brain. If we can remove the clot within 1 hour after stroke onset, most patients recover on the Cath Lab table. This is our management of acute stroke in the Cath Lab. We are doing a great intervention. All of a sudden, we realize that the patient stops talking and cannot move his hand anymore, and we call Dr. Neuro. That's similar like standard procedure. Dr. Neuro arrives in the Cath Lab. At that time, we already have done the cerebral angiography. If it was a large vessel occlusion, we already have done thrombectomy. Dr. Nori does an almost full examination on the patient on the Cath Lab table. I will show you a case example. This is a neocord procedure. Many of you are aware of that. It's a transapical access, insertion of the delivery instrument into the left ventricle, leaflet capture. White lights confirm leaflet capture. Gore-Tex suture is grabbed by a needle. Needle is pulled out together with the suture. Delivery instrument is removed, and then tension is applied to eliminate leaflet prolapse. It's a completely echo-guided procedure, does leave all other options open. Posterior as well as anterior leaflet prolapses can be treated, allows very precise adjustment of the chordae on beating heart, much better than we can do during open heart surgery, tells me my surgeon, has become our treatment of choice, not only in high surgical risk patients. It does require general anesthesia. In contrast to mitral clip, we have learned the hard way that the transapical access seems to be more traumatic than the transapical access. For TAVR, bleeding and risk of rupture, you always need a cell saver. And we discussed in the heart team, actually not long before this procedure here, this case here, we have to reduce the risk of bleeding complications. Stop anticoagulation and aspirin Plavix several days before the procedure. Give heparin only after access to the LV has been obtained. That means insertion of the delivery instrument. And don't do this in elderly, frail patients, especially not in women age older than 18 years. The setting where we do this procedure, tertiary referral hospital, 3 times larger than ours, all sorts of departments and specialists, on-site cardiac surgery, surgeon very experienced in transapical TAVR, experienced cardiac anesthesis, best institution, experienced proctors for neocord, as for TE as well as for surgery. And this is the patient history. 80-year-old female patient, Euroscore was 8, severe dyspnea since 3 months, TTE and TE showed severe mitral valve prolapse in P1 and P2, interdisciplinary heart team decision, neocord. Remember, I just told you, don't do this in elderly, frail patients, especially not in women over 80 years. Come on, this patient is 80 years, so it should be okay. The interdisciplinary heart team is one of the greatest innovations in the past decade. Brings together the experience of different disciplines. Unfortunately, it also brings together the complications of different disciplines. But it enables us to do interventions we could not do in the past. It distributes responsibilities. Even if you are the primary operator, it is not your fault because everything was a heart team decision. Some minor initial problems in this case. The anesthetist told me intubation is somehow difficult. Short episode of hypoxemia and blood pressure drop, but stable thereafter. Cardiac surgeon during mini-thoracotomy said soft tissue, typically elderly woman, and very nice family in front of the Cath Lab. Why does this take so long? And this is the TEE. You can see severe eccentric MR due to P1 and P2 prolapse. Insertion of the neocord delivery instrument, 2 chordae could be implanted. And then the echocardiographer said, there is something. It's a clot. It's a clot at the leaflet. And there are more bad news, severe bleeding from the insertion site at the LV apex, complex repair with multiple sutures and patches. Finally, hemostasis could be achieved. Obviously, no additional chordae could be implanted after these two initial chordae. And then the echocardiographer said, good news, I don't see the clot anymore. And the interdisciplinary heart team asked itself, where's the clot? At that time, the anesthesiologist told me unequal pupils. And the angiogram of the right internal carotid artery showed there's a thrombus in a branch of the right medial cerebral artery. You see where the arrow is. Stroke neurologist Dr. Neuro came to the Cath Lab. This will cause a big stroke. Patient is in the time window, so IV lysis is indicated. And the cardiac surgeon said, are you crazy? You want to do what? This patient just underwent complex repair of the left apex and so on. I said, so please give me a balloon-tipped 9 French guide catheter, a microcatheter, and a stent retriever. The Cath Lab nurse told me, very sorry, we do not have that. I asked Dr. Neuro, what should we do now? And he said, according to the guidelines, level 1A, the patient has to be transferred to a tertiary interventional stroke center for urgent embolectomy. And Dr. Serge said, do you want to do what? This patient just underwent a very complex surgical procedure. You cannot transfer him. Dr. Neuro, that is no problem. According to the guidelines, level 1A, we have a contract with the tertiary interventional stroke center nearby. They have an interventional neurologist, Dr. INR, who will come quickly and perform the urgent embolectomy according to the guidelines, level 1A. He always said that. Excellent. Please remind him that he should bring with him a balloon-tipped 9 French guiding catheter, a microcatheter, and stent retriever, because we don't have this in our lab here. Dr. Neuro called the interventional neurologist, Dr. INR. We have a patient with an acute stroke who can, according to Dr. Serge, not be transferred. Please come immediately to perform the urgent embolectomy according to guidelines level 1A. Dr. INR, no, I cannot. I cannot come to your hospital. So please ask him that he should please send a balloon-tipped 9 French guiding catheter, microcatheter, and the stent retriever via taxi. Dr. INR, no, I don't want to do that. So please order a balloon-tipped 9 French guiding catheter, microcatheter, and the stent retriever from our hospital via taxi. Finally, 1.5 hours later, sheath in the carotid artery flushed intermittently, a balloon-tipped 9 French guiding catheter, a microcatheter, and a stent retriever arrived from our hospital via taxi. So we could perform the urgent embolectomy according to guidelines level 1A. This is the stent retriever in place. And then you can, in the next Cineron, you can see the retrieval. It's hard to see, of course. You can see the retrieval of the stent retriever. And this was the clot that we could pull out. Small clot for us, big clot for the patient. I thought, wow, due to the tortuous intracranial vessels, this was one of the most difficult embolectomies I have ever done. And Dr. Neuro, who kindly joined me at the Cath Lab table, said, wow, they never told me that embolectomy is so easy. This is the angiogram of the right internal carotid artery before and after, and you can see restoration of flow in this small vessel. Discussion with the family in front of the Cath Lab, severe complications, but it looked like we could fix them. Good result regarding the mitral valve. We are optimistic. Unfortunately, this was not the end of the story. Follow-up CT did not show any stroke signs, so that was good. However, during that night, the patient still intubated suffered from a severe pneumothorax, subcutaneous and abdominal emphysema caused by a tear in the trachea. And remember, some minor initial problems. The anesthetist told me intubation is somehow difficult. Short episode of hypoxemia and blood pressure drop, stable thereafter. shock, CPR followed by multi-organ failure, brain edema, surgical repair of the tracheal tear, mediastinitis, renal failure, dialysis, patient state comatose, they expired on day 12. So lessons we learned: small clots can cause a major stroke, and many small details can have a major impact on the overall outcome. The interdisciplinary heart team is a new invention, but working as a team in the interest of the patient is as old as medicine. Do never believe that for infrastructure, that your infrastructure is good enough. Do never believe that a team decision does take away your responsibility. Key points: the acute embolic stroke, embolectomy in addition to IV lysis, if indicated, has become a class 1A recommendation. It can and should be done up to 6 hours after the onset of symptoms, in selected cases even after that. But every minute counts, time is brain. Cardiologists can and should become involved. If a stroke happens in the Cath Lab, this is the best place to be. The patient should not be transferred to somewhere else, but treated immediately. That's why we have created this society which facilitates training in these interventions for cardiologists. And again, this is our conference about interventions. Thank you very much for your attention.
The most interesting are the conversations. So the message is that never lose sight of the entire patient, because here we lost him, although it salvaged everything, but a trachea took him away, the injury over there. Yes, Dr. Hajra.
Yeah. Nowadays, in our hospital, we keep penumbra system. The penumbra system is around $3,000. And it's just like microcatheter. So you can just pass this microcatheter over 6 French guide, and you can avoid the solitaire-like stents. Because the solitaire stent is not being sold to the cardiologists in our hospital. Only
Do
the
you know why?
I don't know why.
Because the INR community said to the companies, if you sell it to cardiologists, we will not buy your devices anymore.
So my humble,
Happy to hear that you have turf pedals here as well.
the humble suggestion would be a penumbra system should be available in most of the structural heart disease. Very simple and cost only $1,000.
Yeah, the penumbra system is a good system, but it does not work in more than about 70% of the cases. So it's actually the combination of both is the way to go.
Finally, you were able to do the process because you finally were able to have the gadgets in your Cath Lab. Finally, you were able to get rid of this embolus because you were able to arrange the system for you. Let's say somebody is working here and he is not able to have these things, and we have a window period which is short in these cases. In the presence of obvious contraindication for a systemic lysis, is there any role of a smaller dose of thrombolytic into the middle cerebral artery through a microcatheter? Because some of us have had an experience of using smaller dose into the intracoronary.
So that was what we did before we have these devices available. So we went in with a microcatheter. That was actually my first stroke intervention in the 90s, with a microcatheter, a whisper wire, any soft wire, and then give local lysis via the microcatheter and try to just cross the lesion and try to mobilize the clot. And that actually helps very often. But I mean, today and these days where the devices are available and with all these turf battles is more difficult than in the 90s.
Sometimes just flushing this clot away into the distal circulation can decrease the area of infarct, which we have done it.
Just crossing with the wire very often helps.
Yeah, crossing will help you, but at times you cross with a wire, and if you have nothing and you have obvious contraindication, you can just flush it, let the clot break and go distally, because then the quantum of ischemia or the penumbra will also be smaller.
If it is a soft, fresh thrombus, then
yeah, it was a fresh because it was fresh because it formed during the process.
Some hard material, calcium, which has gone up, then
so that will not be responsive to any thrombolytic. You see, thrombolytic is only fresh thrombus because it formed. Yeah, and something which forms and goes away, I think, has to be fresh enough.
Yes. Any other comments over there? Yeah, Henny.
Thank you very much. That was amazing.
Mike.
Thank you very much. That was amazing. And I'm following all the conversation. Obviously, we also, I think every cardiologist should learn acute stroke intervention for the complications that we cause. Especially now that we go radial, we are treating very, very elderly patients. And I think, I took a screenshot of Dr. Siver's with the organization, because we all do primitive things which work. I mean, partly at least, like trying to cross with a wire, a balloon, injecting local TPA if we can reach. But why not? Should we learn how to have? I mean, if we don't work, we don't allow ourselves now to work without stent grafts, right? When we have a perforation, a stroke is probably 10 times worse than a perforation. So we should all learn this, and I call on all of us to join hands and go to the website and get the devices and learn it. We should do it.
It's not only for the complications we create. It's not only for the complications we create at the Cath Lab. It's actually for the daily patient which comes into your hospital. If you don't have an INR in your hospital, talk to your neurologist. Remind him of this guidelines level A1. And then he may be able to follow you and join with you, and then you can build a team and learn these procedures. It's actually the most important procedure I do in the Cath Lab. So compared to TAV or mitral, this is all not bullshit, but this is all. It's not important. But when you have our youngest patient was a 16-year-old girl, completely hemiplegic. If you remove the clot and the patient comes away from the table and can move and speak again, this tells you what is important.
That small little clot can really tell you as to how much it had cost. So
Yes.
I think that is, but one very important thing for us, all of us to remember, is that the moment the vessels they enter the cranium, they lose adventitia. So your intracranial vessels are without adventitia. This is only intima and media. Second is they're all very tortuous. They are much more fragile. So you cannot translate your coronary intervention state
They're
of
hanging
into the
in
one has
gel.
to be extremely gentle. We have to really learn and have the hardwares. Like whisper wire is okay, but nowadays we have 2 or 3 wire. They are much more handy to travel into these tortuous vessels, much less traumatic than whisper wire.
It's actually not difficult to learn. Actually, the most difficult part is getting access, where actually many neurointerventionists fail because they are used to coil embolisms in younger patients. We are actually more experienced if we do carotid stenting. We are more experienced with that. And as soon as you have the sheath in the distal internal carotid artery, the rest is easy to learn. And we offer training models. You can test this in post-mortem settings, on models, virtual training, everything is available.
At your level, it may be easy, but I think for most of us, we will have to keep these things in mind and go slowly.
We need to take clues and initiate such training
Well-
programs. Maybe next time we will plan something like this.
Can I say just one thing? I mean, here we have Horst Sievert, and we know how he works. We know what he does. There's not a single opening in the body that he hasn't intubated yet. So he's extremely very knowledgeable in many areas. I think we have to be very careful to just extend this. I mean, it's fun to look at this, and for the patient, it is extremely important if you are in his hands. I would like to caution that when you don't know how to do this, you can do more harm than good. And let's not forget, the vessels in the brain are not acting like the vessels in the heart, and all these things you have to learn. Unless you have a good training, I think we have to be careful, with tremendous respect to you, Horst, but I think we have to be careful to just say, well, let's do it all together. And then, we break vessels and, we do all things that eventually we don't know what the consequences are.
Okay, but that's what I said.
Yeah, I know.
The issue is not buying the device from the company and then move ahead. That's something you should not even consider. But if you have passed a training course, training in a model, observation in a stroke center, that's what we organize, and then proctoring by telemedicine, then I think it's something which any interventionist can learn very, very easily. And the vessels are fragile, yes, but an unstable coronary plaque is also fragile. And it's not such a big difference. It's just different, but not more different.
I mean, Horst is young, but in many respects, he's still a dinosaur as far as interventional cardiology is concerned. As I said, if you go into his lab, he knows everything about everything, and that's why we have to be careful to take.
probably is one of the most complete
that's a big statement coming
interventionist
from a
ever.
person like Eberhard. So it means a lot. Thank you so much, Horst. Let me invite Dr. Bali, our expert, Professor Bali, ex-PGI, very close friend, and now based out of Paras Hospital, director and chairman.
A brief comment before that. Host cannot feel younger in the
We'll take
presence
more
of...
comments later.
No, host cannot feel younger in the presence of Eberhard.
Yeah, sure. Over to you, Dr. Bali. So, out of the structural world, we are going towards the coronaries.
Correct. Thank you, Dr. Atul, for inviting me to this wonderful conference. And it was a Saturday afternoon, and I had invited a few guests at home for a party. So I wanted to finish the case in about 2.5 hours, and ended up doing a procedure for about 6 hours. 80-year-old female had diabetic hypertension, presented to us with acute coronary syndrome and heart failure. She was in left ventricular failure. We treated her medically. And echocardiography showed that she had an inferior akinetic segment. There was a regional wall motion abnormality in the LAT territory. She had mild MR, and ejection fraction was 20%. ECG showed an ST elevation in AVR and depression in 1 AVL V2 to V6. We managed her left ventricular failure, did a PET scan, which showed that the inferior lateral wall was non-viable, the rest was viable. So after stabilization, we took her for an angiography, and this is what we found, that left main LAD was very heavily calcified, and circumflex was non-dominant, and there was about 80% stenosis proximally, and then there was a total occlusion. And LAD heavily calcified, mid had 99% stenosis, and the calcification started right from the ostium of the left main. And this is the right coronary artery, ostial about 95% stenosis, heavily calcified artery. We talked to surgeons, in fact, we talked to 2 cardiac surgeons, and both felt that there was no surgical option for her. So we decided that we were going to proceed with a protected PCI in this patient. We thought about rota considering her heavy calcification, but she had severe left ventricular dysfunction, a recent ACS, and heart failure. So we thought that we should not use rota. IVL was on board, but if we were going to use IVL, we were talking about a 2.5, a 3 millimeter, and a 3.5 millimeter IVL, which would have pushed up the cost significantly. So we thought that let's go ahead and see the result of balloon angioplasty, and then decide whether IVL would be needed or not. From the left femoral artery, we put in an Impella 2.5, and after seeing the condition that it was working nicely, we proceeded with right coronary angioplasty. We crossed with a BMW wire, did an angioplasty with 2.5, and 3 millimeter balloon, and then did a stenting with 3.5 millimeter stent, 18 millimeter in diameter. Post-dilated it, there was some under expansion. We went ahead with a 4 millimeter balloon, and after 4 millimeter balloon, we got a very good result, and this was the final result we got. So we went to the left side, and we crossed this critical narrow lesion in the mid part of LAD with a filter XT wire, changed it over the microcatheter with the BMW wire, and did a balloon angioplasty with 1.5 to 2.5 millimeter balloon. But after that, the 2.5 millimeter would not go, so we put in a guide liner to help us cross this lesion, and did a reasonably good balloon angioplasty, and dilated the entire segment at high pressure, then took a 2.75 millimeter balloon at 24 atmosphere, and I thought that we done a good balloon angioplasty in this particular patient. And then we did a 3 millimeter balloon angioplasty also, high pressure, 24 millimeters, and then we thought that the angiographic result was good. And this is what we had angiographic. I thought that we could go ahead and put in a stent. So we put in a first stent, distally 2.75 millimeter Zions expedition stent at 16 atmosphere. The guideliner was there. And then we took a long stent, 3 into 38 millimeter Zions expedition. And the stent moved very nicely. But when I was going to withdraw the guideliner, I saw that the guideliner has broken. Very gentle withdrawal, as we normally do, but the tip of the guideliner has broken. And I thought that we should try to get this guideliner tip out So passed a balloon beyond the guideline tip and tried to remove the entire system, but there was so much of stretch on that I was concerned that we may break the balloon as well. So removed that out and tried to do balloon angioplasty again to see what we tried to pull it out. Then I thought that maybe our balloon is going okay, and I can deploy a stent, and probably the stent, radial stent, should take care of this guideliner tip. Now we deployed a stent, and this is what we found, that the guideliner tip is not inflating. So we had a critical narrowing at that site, and then we tried to balloon it, did not succeed, and we got a lot of time was taken in this procedure, and the guide wire came out. So wiring it again was again tough because the angle of the tip of the guideliner has changed. So entering into that was a little tough. Crossed it with a filter actually wire, tried to dilate with 1.5 millimeter and 2 millimeter, but nothing would go beyond that 2 millimeter. So then I took another guideliner to help in crossing the guideline, the broken tip of the guideliner, and dilated with 2.5 and then with 3, but every time it would come back. And then I decided that let's take an OPN balloon. And this is what we took, an OPN balloon, and at 40 atmosphere, we fractured that tip of the guideliner, broken tip. And then dilated with a 3.5 millimeter. You can see this is a breaking of the broken tip. And we dilated it with a 3.5 millimeter, optimized that stent. .5 millimeter at 24 atmosphere. Then with the same high pressure balloon, we dilated the left main. And after left main dilatation, we saw that this time in multiple views that the balloon expansion is very good. And this is a 3.5 millimeter balloon, nicely opening up. And then we deployed a 4 into 18 millimeter Zyme certification stent in the left main, and dilated that with a 4.5 millimeter balloon at 24 atmosphere to optimize the stent. And this is what we got final angiogram. So the procedure which I thought we would finish in 1.5 hours took almost 4 hours. So impella was removed in the Cath Lab, patient remained stable, and this is what we found, the guideliner tip was broken. And this is a normal guideliner and the broken tip of the guideliner. So patient made an uneventful recovery, was discharged after 3 days. She's doing very well at 5 months follow-up, but we need to keep a follow-up subsequently to see what would happen to that tip of the guideliner, which is outside the stent. I hope no aneurysm forms at that site, but a check angiogram is planned. So what I missed on this time, because of the compulsion of Saturday and a party at home, we should have done an imaging in this particular patient to know how much was the extent of calcification. Block modification would have been helpful. Rota was obviously a problem because of a severe left ventricular dysfunction. ACS and maybe IVL could have been used. I haven't come across any guideline tip fracture in literature, but there may be some operators in this room who may have had this experience. We got that tip, so the tip can get trapped in the calcium and rarely break. We found that high pressure, you can break this tip and then do an angioplasty stenting. So that is all. So sometimes simple procedures do become complicated. Thank you. Thank you very much.
So finally, the guests waited for you. The guests waited for you that day. Okay.
Another very good case, but I think the amount of calcium this patient had, and you had already put in Bella, I would have done root ablation. But to deal with such vessels without root ablation is very difficult.
Topic is rota regret. The topic of the case is rota regret.
I think it should be rota regret.
Yes.
Can I have a comment?
Sir, what type of excuse me.
Yeah, please.
What
After
type
that,
of treatment actually you use post PCI, DAPT or single or antigonal with aspirin?
Dual antigen.
Okay.
She was 80 years old. We used aspirin and clopidogrel.
See that it's a foreign material. Can we use a rivaroxaban 2.5 PD internose and along with single aspirin? What is your thought for that?
You know, this is outside the stent, and we have a very good free flow. And many times we have seen that we do plaster a stent also once the lost stent is there inside the coronary artery. But this is an individual case, maybe case to case you can decide. But I thought that we could use only dual antiplatelet drug. But there is literature available on using a triple antiplatelet drugs or a NOAC along with a dual antiplatelet drug. But in an 80-year-old lady, a frail lady, that would be a problem. So I would personally not use.
Dr. R.D. Yadav? Yeah.
Yes, sir. Sir, this is not a guideliner, this is guidegila. Number one, this is guidegila. This is not guideliner. I have similar experience. I was doing similar case, calcified, and guideliner doesn't break. Guideliner, newer guideliner, V2 is very good. V3, newer one is even better. It's the guidegila, green one is the guidegila. And that guidegila broke at the joint also. So you have to go with the balloon, or you are on the wire, balloon distally inflate and come out with that. Otherwise,
I tried all those maneuvers, and I think I showed you that.
This guidegila.
There was so much of stress on that particular balloon that I was concerned that the balloon may break, balloon shaft may break. And what it did when I was pulling the balloon was that instead of coaxial, it made it angulated. So entering into that was even more difficult.
So go distally and then inflate and then come out together.
Yeah, these things are easier described. We do snare also intracoronary.
I had done and removed very easily.
Suggestions well taken. Dr. G.L. Sharma?
Sir, similar episode we had. We were doing the angioplasty of right coronary artery. The tip of the guiding catheter is broken and it remained inside the RCA. We did the stenting, we did the ballooning, and we thought the things will be happen normally. But after 6 hours, there is stent thrombosis, and again we put it the stent, and patient is doing well.
Excellent. Can we have Dr. Balbir Singh's?
A couple of comments. I've had a similar problem.
Just a minute, let him complete. Can we have Dr. Balbir Singh's presentation?
Godzilla was new or export one?
Yeah.
ETO was ETO?
It was in New York. It was in New York.
Majority of the time you are trapped because of the ETO. Whether it's balloon or, but less likely.
I have a good experience. Guidegila is very weak at the joint as well as at the shaft, but its the profile is very good. You can put deep. That is the advantage. Otherwise, guideliner is much better, more stronger, and rarely those things happen.
Dr. Vijay?
I've had a similar experience about 15 years ago when we broke the tip of a diagnostic catheter, which was of course taken out very easily by passing a balloon. But in Dr. Bali's case, we've had discussion outside just before presentation. I think a couple of points which I thought would have possibly helped was, one is as you're trying to pull this tip of the guide liner by inflating a balloon distally, the proximal edge of the broken guiding catheter will have a razor effect, and in a calcified environment it may be difficult to get out. So I think it will maybe good thing to have a reverse bat. And how do you have a reverse bat is have a relatively longish balloon, because any balloon can be, because this is just a short segment, you can have a balloon distal as well as proximal. Now as you pull this inflated balloon, the proximal part of the balloon will act like a bat. As you're advancing anything to the radial have a difficulty. Same thing as you're trying to withdraw, this would have, according to me, would have possibly very easily come.
That's a nice
Second
suggestion.
thing is, since your guide, the tip of the guide zilla was not expanding, I think it would have been a simpler idea to take a cutting balloon and blow it up. That would have transected it longitudinally, and that would have helped you in just deploying a stent easily. Or it would have helped you in getting it out. Maybe these two things could have tried. But I think finally you manage it. 4 hours you are.
Yeah, you
did it in
saved him half an hour.
Yeah.
That's true. Thank you very much, Dr. Bali. Excellent. And Dr. Balbir Singh, the chairman and chief of cardiac sciences at Max Saket Hospital, and he's my former colleague at All India Institute. He does all kind of interventions: coronary, structural, endovascular, and electrophysiology. So that's all-in-one. So let's see what Balbir is showing us. It's a secret.
Thank you, Atul. So we have a catastrophic complication, and we don't wish these to happen on Saturday, but this was also Saturday, and I had no guests waiting, neither I had to go for any party, yet it happened, and I had full time with me to handle it. So this is a 60-year-old long-standing diabetic, recent ACS, drop positive, ECG changes, ejection fraction 40 to 45%. This was his ECG, looks quite stable, no oxygen failure, but the creatinine was 1.6. So obviously we wanted to do an IVUS guided procedure. So this is his right coronary artery. If we watch carefully, we see some collaterals going to the distal part of the LED. You can see this is an LAO projection. And if we push this again into an RAO projection, you see some fade filling of the LED. This is the LED. You see a big diagonal, osteal lesion, and then mid LED is blocked. Large circumflex, something in the left mid, it's mild disease looks like. So we have the second view which clearly shows the LED is blocked. So I've taken all the loops so that you feel that as if you are in the case. This is 16th July, time is 10:48. So we're wiring both LED and diagonal. So this is the first wire. This is a BMW wire. So crosses quite easily into the LED, telling us that this is a recent occlusion, even though there are some collaterals. We get another wire, another BMW into the diagonal. And now we have an IVUS. So this is the time I decided that let's do this patient now IVUS guided. We'll forget about more contrast. Doesn't look that difficult. We have two wires. We'll put another wire in the circumflex. So we have all the guides to help us understand. I will visualize the ostium of diagonal with IVUS to decide whether I want one stent strategy or two stent strategy. So this was the stage. We got the IVUS. This is a very important IVUS to see. I will get back to this IVUS. So this is an IVUS run from the distal part of the LED. Distal part of the LED was dilated with a 2 millimeter balloon. The proximal has not been dilated as yet. So this is the distal part of the LED. You can, I don't have the markers to tell you. It was about 2.5 vessel and proximally it was 3.5 to 4. But as we come, proximity is what we need to see. So this is a dense plaque as we come proximally, but as we come, this is the diagonal which has finished. Now we are in this part of the lesion. So we'll visualize this part. So it's a plaque which is a heterogeneous plaque, lipid, soft plaque, and there is a halo surrounding this plaque. You see a black round halo surrounding this plaque. You see this? I will show you an image also. You can see this on the transverse view also, that from here to here, you have a black halo surrounding this plaque. Now you come across the other branch, we're coming across circumflex. The plaque is at the ostium. We know that its ostium is involved. And there was a minor plaquing of the left main, which we saw. So this is what it was. This is the halo I'm talking of. There's a big vessel, a positively remodeled vessel. This was beyond 4. So the proximally, it was positively remodeled with a large black structure around it, which is most likely a hematoma. And I have not dilated this vessel as yet. This is one of the case reports published in Circulation 2003. You have a similar hematoma around this. This was the vessel. This was the plaque. Seeing this hematoma, the operators did not do anything. They did not stent it and left the patient on follow-up. The patient had acute occlusion after a month and had a large MI thereafter. So this is how hematomas can behave. Let's see what happened in our case. So then we have a wire in the circumflex. We have dilated the distal part with a 2 millimeter balloon. And now I was getting the 2.5 millimeter balloon down. You see I was having some friction because probably the circumflex wire was causing me trouble. So I removed it, got the balloon down. We dilated this balloon in the proximal part and immediately thereafter realized the flow to the LED was reducing. So this is 11:59 and within minutes the patient crashed and you see the massage is on. There is no flow across LED, circumflex, left main all occluded, and we are going with a 7 French radial approach. So about 15 minutes of massage, some flow comes back and again it stops and the flow reduces. We go back and see that some flow is back now and the patient's pressure started coming to 80, 90, but he had another cardiac arrest. Now this time what we did is we punctured both the groins, had an IBP inserted while the massage was on, and had a guiding from the femoral. With the massage, the pressures came back and the flow also started. Now you can see the ostium of the circumflex is pinched and the flow across LED and diagonal are reduced markedly. Now we have 2 wires from the radial approach, getting 2 wires from the femoral approach. So that secure everything so that we can go ahead. Radial was giving me trouble because of the spasm and so many things happening on the shell. So now we had the radial and the femoral guides both in. At that stage, I passed 2 wires from the femoral, quickly stented from left main to LED. So I see that the flow to the diagonal is now compromised, so there is some osteal stenosis of the diagonal. We went ahead, recrossed through the stent again into the diagonal, removed both the radial wires. Now we were secure from the femoral system with 3 wires. At this stage, we removed the femoral radial wires and the radial guiding and got in another stent from diagonal to LED. So we had good flow across the diagonal. I was now least bothered about the LED distal because I knew there was some collaterals. I just needed to be very comfortable with we did a pot on the left main and then thought, let's look at the circumflex. So there was a severe osteal pinching and obviously the hematoma had migrated to the circumflex osteal. So the tap was the most obvious way to handle this. So this is a tap. So tap followed by a kissing balloon. This was on the stent boost. So properly positioned, followed by a kissing, and then a pot. This was the final picture. Waited for stabilization for 15-20 minutes in the lab. Well optimized result with a 4.5 millimeter balloon. This was the picture, and a final IVUS run was taken, which showed reasonable good expansion of the stent. We see the hematoma had been compressed, and I did not take a run from the circumflex, but I was very, very clear that I want to look at the left main well and the carina. So there was something hanging in the carina, some struts. I didn't want to go back because I wasn't sure what it was. I didn't go back. The patient did very well. Next morning, he was extubated. He has his meals in the afternoon. On a Sunday, I went to see him about 8:30 in the night. He had his dinner and was absolutely fine. So the antiplatelet regime was Disprin plus Brilinta, heparin, and Tirofiban on the day 1 was given. So he was continuing on heparin. Balloon pump was working well. 8:30, he had his dinner. He was given a sleeping pill because he wanted that. At 12:30, I get a call that he's had a cardiac arrest. And so the joy was short-lived. I had to rush back with a cardiac arrest, so another CPR. So what could have happened? Obviously, a stent occlusion was the most likely thing to have happened. So about half an hour of CPR, pressure started coming up. We didn't know about the brain. This was the ECG, which showed an ST elevation in AVR and a QRS, which is broadened. Heart rate was 175. So at that stage, we were not sure of the neurostatus. We were not sure of what his pressure is going to behave. It was 100 pressure. But we decided to take him to the Cath Lab. This was in the Cath Lab. The LED was flowing. There was a thrombus at the mouth of the LED and the diagonal. And there is something in the stent within the LED. You can see something happening in the stent. Now I didn't want to get into another imaging. This is, you can see, at 2:36 a.m. on Monday morning now. This is happening on Monday morning. So I have a tap done. I have something in the stent. What is to be done? So I went back with a balloon, wired both of them, went back with a balloon in the LED, a 3.5 balloon, repeated the case, but it did not change the picture at all. I was clear that LED I want to address now. I will see what happens later on. So nothing happened. It was the same situation as what it was. So I converted this tap into an inverted crush. So I crushed the tap stent, converted into an inverted crush, put in another stent, a 3.5 long stent from LED to the left main, and post-dilated with a 4.5 pot on the left main, did a final kiss and a final pot. This was the final picture which I left with. I have a clot in the LED, which I did not bother because I knew there were collaterals to that. We can handle it with pharmacological therapy. You can see what happens later on. But this was the result on the LED and left main. Patient did very well. He was extubated 48 hours later, walked out of the hospital, total of 5 days stay, and with a normal echo. He came back for follow-up at 2 weeks and doing extremely well. It's asymptomatic, normal ECG.
A lot of hard work and a great salvage. This patient was. It's really hard to work on a weekend like that because you've got a whole week ahead of planned cases. So, Vijay?
Real catastrophe. Is there a possibility that some air went into circumflex?
I don't think so.
Because if you look at the time when you had that catastrophe of LAD blockage, the flow in the distal circ is too less. I think a compressing hematoma, which gets compressed from LM, LAD towards circumflex, should be restricted more towards the os. And even if it goes there, I think even if you create an 80% obstruction at the circ os, usually flows are not limited so much. I think there is a tremendous reduction in flow in the circ.
Okay,
And
so I'll answer that question because very unlikely to happen. I guess we have gone a long way over air embolism in patients. We've not had any for many years. Second thing is that when you look at the shot that was after CPR, there was no stent there. The circumflex ostium showed a haziness and severe pinching, which could only happen if there is a hematoma. If it was air, it would have come back to the same state that it was when we started.
Somebody whose LAD is largely gone, then shooting something into circumflex, I don't know, because at times we have seen the air getting into circumflex with saline, which is not picked up angiographically.
Right, so but air would not cause the circumflex to become pinched, so badly pinched.
And the later pictures were not.
There is pinching because of hematoma. What I am saying is, the hematoma causing pinching at even 80% obstruction usually does not lead to compromise of the circulation at rest.
So the moment
And it was a hemodynamic collapse.
No, a hematoma can sometimes really impinge upon your lumen. So
Then then the vessel will be stopping at the origin.
Yeah.
In this case, there was a couple of both the things.
I have a
pinching
question.
as well as possibly something going into distal circ, because
What's the role for a cutting balloon in intramural hematoma?
Yeah, so
did you think on that?
How cutting balloon can maybe open that hematoma and
Yeah, we have used cutting balloon many times and it's able to drain the hematoma. IMHs are very easily drained. You don't need any stent.
Yeah,
we have demonstrated it echo-wise also. You have a trap blood there. You do a cutting, the blood is released, angiographically looks fine, and the schema is
not
good.
in this patient, you see a dense plaque followed by a hematoma with a positively remodeled vessel. You can't leave a
No, this was into the circ. He's asking about cutting balloon into the circost.
Yeah,
that could
wherever you find the hematoma, you cut it,
circost could have been.
decompress it.
Anyhow,
it won't extend.
Is like the situation of this patient when you already massage.
It more than tremendous
This is a
effort.
very difficult story, so it's just a theoretical talk. Thank you so much, Balbir. A big hand. Dr. Claire has the last
I
thing.
just want to ask you that what information you got from the imaging before proceeding, and how did it change your policy to deal with this case?
Okay, so the information was a lot actually. So it had showed us that I had done imaging from the LED to the first thing it showed me was that my wire was not in the LED proper, it was in the side branch. That was the first information I got. Second, I was dealing with a positively remodeled hematoma and I undersized the balloon in the proximal LED, which was 2.5. I was not expecting that this catastrophe will happen with 2.5. I was thinking how to stent it. In fact, the vessel size was coming as 4 and I was thinking I put a 3 stent and let's see what happens and then see. So it also told me that the left main was also had a plaque, so I would need a provisional stent from left main to the LED. So I don't think that, and made me learn much wiser that if I get a hematoma like this again, I would think twice before I intervene again, and maybe Rajneesh is there to do a much better job than us.
Great case. Very nice case. Thank you so much, Balbir. Thank you. I'm going to ask Dr. Manik Chopra. He has to get on the flight to do this case, and then Dr. P.K. Hasra.
Good evening, friends and colleagues. So this is regarding a aortic parabola leak closure case, and as such, no conflict of interest because this was a device closure. This patient has a 80-year-old female, frail, rheumatoid arthritis, previous 2 surgeries, 2009, 2014, was a SAVA with Magna 19 with aortic root enlargement in 2019. This was done in 2019. 1 month post SAVA, if you see the peak and mean gradients, they were around 35 and 17. There was mild AR, there was no clear mechanism for AR, whether it was valvular or paravalvular, that was not clear. There was mild MR, mild TR, PA pressures of 48, moderate pH, and LV ejection fraction of 55%. The patient was doing well till January 2022. She also had COVID in between and she was able to tolerate it well. The gradients remains almost similar. But then she developed dyspnea on exertion since last 3 months. That would be from January to March. And she ended at last 3. And she ended in heart failure requiring hospitalization. On transthoracic echo, the left atrium was enlarged, LV was slightly enlarged, right atrium and right ventricle were normal. You could see that the peak and mean pressures had increased, like 68 by 34 millimeters of mercury. AVA was 0.9 centimeters square. LVOT VTI by aortic VTI was 0.38. And there was a mildly restricted movement of the LCC. There were 2 PVLs, one 5 or 6 millimeter, which was posteriorly related to Ncc. And there was a second PVL, which was around 3 to 4 millimeter related anteriorly to the RCC. There was no valvular AR, holodiastolic reversal in the aortic arc. This patient was basically referred for TAVR to some center because it appeared that all this AR is central and the gradients are high. Patient also had severe MR, probably due to annular dilatation, moderate TR, PSV of 60, severe PH, and ejection fraction of 60%. It appears that whatever AR was reported on earlier occasions was basically PVL, which leads to a garden house effect in LVOT. Now, the TE and coronary assessment were done. TE showed similar findings. I could show you the TE movements, and this is a typical short axis view. You can see, I'm sorry, I'll go back and I'll try to play it again if I can. If you see that these 2 leaflets are moving very well, you don't expect them to move any further. They are completely moving. The only thing is the left one is restricted, and that is what would probably go into the category of leaflet thrombosis, to best of my understanding. Now, if you come to this view, you have 2 pictures, one on the left hand side and second on the right hand side, and this is again a TEE at 140 degrees. And if you see there are 2 PVLs, one is anteriorly, one is posteriorly, which is very large, and it is related to the non-coronary cusp, and one is sort of anteriorly, which is related to the right coronary cusp. And if you see these 2 leaf, one is here and one is here. The right one goes exactly perpendicular and hits it here and fills whole of the LVOT, which gives an appearance of central AR, especially on transthoracic echo. I can run it again for you. And then this is the degree of mitral regurgitation. This is probably all secondary to the aortic pathology. Now, since there was no transthoracic echo, which was before 2020 for comparison, all the symptoms were since last 3 months. And the LCC leaflet was not moving well. All the other 2 leaflets were moving well. To my mind, it was LCC leaflet thrombosis, which is leading to LCC mobility, immobility. And in conclusion, I would say that the PVL was moderate to severe. AS appeared to be moderate to severe. Now, there are 3 components. One is leaflet thrombosis. Second is small aortic valve area, which is secondary to pre-existing patient processes mismatch because it is Magna 19. You also have PVL, which would increase the degree of flow and then also attribute to increased gradients. And you also know that probably the LVOT VTI to aortic VTI ratio is more than 0.25, which indicates that definitely the stenosis part is not so severe. So to best of my understanding, his symptoms were mainly due to regurgitation. She was discharged after LMWH for 5 days because we wanted to treat the leaflet thrombosis part. And then anticoagulation and aspirin. She was called for a follow-up after 7 days, and there was melena, drop in hemoglobin, required stopping of anticoagulation and aspirin. Blood transfusion was given. She was kept on aspirin and then advised GI workup. She opted for medical management and she wanted time to think. Risk benefits were discussed and patient was discharged in NOIG class 3. She was readmitted at least 3 to 4 times. Again, now the patient was willing for intervention. Now, what are the treatment options for this patient? Either you do a redo AVR with MB repair, or you go with a TAVR valve, which would be typically evolute R23 and place the valve really low, and then you crack the surgical valve. Third option is you Ncc and RCC PVL device closure, we followed by a close follow-up for the aortic stenosis part, and you postpone the TAVR to a later date. Now the first option, very high risk for surgery, redo surgery, she's 84, rheumatoid arthritis, frail, comorbidities, GI bleeding, denied both by the patient as well as the surgeon. Option number 2, evaluate R23, placing the valve low and cracking the surgical valve. This may address both the valve as well as the paravalvular paravalvular leak. Now this is not an option because predominantly it is a AR situation, and it's the right RCC PVL and the Ncc Pvl which is mainly responsible for your AR situation. If you fracture the valve, it would increase by 2 or 3 millimeters, but that would be inadequate to seal these PVLs, as you see later on, because they were 5 or 6 millimeters in size. And most importantly, in patients with previous aortic root enlargement, there is a very distant possibility of patch dehiscence leading to catastrophic complications. If there was no aortic root enlargement, probably this might be one of the options, and then we would have treated PVL later on if any was pending. So the third treatment option was Ncc and RCC Pvl closure, followed by close follow-up for the AS part, and to postpone the TAVR at a later date. Now this is considered to be the best option because 1, regurgitation appears to be the predominant problem. A fair trial of anticoagulation for the leaflet thrombosis part is pending. And for the stenosis part, we all know Magna 19 is the smallest valve with a mean gradient which was already 17.5 post-surgery. Now, if you put evolute R23 in this valve, you could easily expect a mean gradient of around 25 without cracking. And cracking is anyway no option for this patient. So probably just treating the PVL would cause some decrease in gradients, maybe from 35 they would come to 30, and probably anticoagulation can still bring it to a lower level. And you would assume probably the same sort of hemodynamic result. The remaining pathology, if you treat the regurgitation and you treat the leaflet partially, then it's just stenosis. And we all know we see so many patients with a gradient of 34. If there is no AR, they do well. So probably you can postpone your TAVR till the symptoms reappear or the LV systolic dysfunction begins. The reason of doing this is that evolute R is a small valve. It's the final card for this patient. If you use it at 84, it might degenerate at 88 because it's small valve and valve, you cannot fracture it. So use it only when it is the last chance. So now come to CT planning of PVL closure. You need to know the location, you need to know the size, shape, relation of coronaries and optimal angle of crossing. TAVR has made us very intelligent in relation to the CT planning, and I can show you how. You can see this is a 3D planner reconstruction mode, and the middle picture is showing you the length and the dimensions of the Ncc Pvl, which is something like 6.7 into 4 millimeters. You can also see the RCC Pvl, which is very thin and long, which is something like 2.64 into 5 millimeters in length, shown in the middle picture. And I can quickly run this. You can see the dots. If you see one of the dots like this, this is RCC Pvl, and just below, and as you rotate it further, it would be the Ncc Pvl. You can also rotate it upside down. So as you understand how is the RCC Pvl, it is very tortuous, serpentinous. This is how on the left hand side of the screen you see the Ncc Pvl, on the right hand side of the screen you see the RCC Pvl. You can exactly get the angles. In this it is RAO 25 and caudal 8. So if you go to the gantry and give this angle, your wire will cross in one trial, one shot. If you don't do this, you will fiddle there for at least 15 minutes, especially for the RCC Pvl. Now I'm showing this RCC Pvl from the lower portion. You can see that it's sort of serpentinous and it's like going almost perpendicular to the LVOT. You can also measure the distance of the RCC Pvl from the origin of the right coronary, so that you know that your device, what should be the device length, whether it is going to interfere with the RCA ostium or no. And then you can easily plan the PVL closure for the optimal angle. You can see that on the left hand side of the screen I have 2 dots like so basically what I have done is I have isolated the non-cusp on the, this is typical of, you can say this is RL cusp overlay or what you call as Ncc side view. And you see that on the left-hand side of the screen, it's the Ncc Pvl. On the right side of the screen is the Rcc Pvl. The idea is to isolate whichever Pvl is there and bring it on one side of the screen so that you know where to cross. And this is the same for the Rcc Pvl. The angle is very acute and typical. It's like LAO 90 and superior cranial 22. But now come to the Pvl closure procedure. It was general anesthesia. GI-scopy was done up front. There was no significant findings. Sheets and RFA, LFA, LFE, NCC and RCC, parabola leak, everything echo was done and findings were same. The aortic pressures were around 40. And this is the aortogram which was done in predetermined views. You can clearly see on the left-hand side of the screen, you can clearly see a large tubular structure, a continuity outside the valve frame, connecting the aorta and the LV, and this is the PVL. This is the Ncc Pvl. Now, if you go to the lateral view, in the front, in relation to the RCC, there would be a small tubular structure, which will you see just below the coronary, in between the aorta and the LV, which is outside the valve frame. I can again show you this. So these were two. This is quite small. Now coming to the Ncc Pvl closure, it was closed retrograde with RFA. Right femoral access, 6 French 100 centimeter MPA guiding with 5 French 125 MPA diagnostic inside it with a thermo straight wire in the determined angle, and it went within 1 second. You can see this is my first shot and the wire goes in. You don't have to do anything. You just need to determine the angles straight in. And then you push the system, you push the MPA inside it, and then this is the MPA going inside, and then like you push your guiding catheter over it, system is pushed into the LV, and now what I'm doing is I'm trying to bring the MPA out and the guiding remains there. I put a Safari XS small wire, the wire which we all like for TAVR because it's a stiff, and then I exchange it for a sheet because it is going to give me a long support. This is a 7 French flexure sheet, 90 millimeters. It's a braided sheet, it won't get kinked. You can also use a 6 French MPA catheter, but 7 French flexor would give you more support, it won't kink. And also you can preserve a wire across and still go with the device. So you can preserve a wire and the device would go by the side, even with 035 wire. That's why I use the 7 French. But since this device, the leak was small, I just removed the wire and went in with the device. You can see I removed the Safari XS small wire, and then I used a AVP2 12 millimeter plug to push in the flexor sheath. This is the plug coming in, and then I deployed the distal disc, and you could see that the distal disc is there just below the frame. And then I also injected something so that I know that my disc is at the right place, and then I deployed the mid central and the distal disc, and this is how it looked like. And then finally I did a sort of tug test for understanding the stability, and then I did an aortogram just to see the position. The leak had significantly decreased. Of course, there's some degree of PVL, which is some degree of AR, which is through the device. And then, the device was released and there was no movement in the device. So it sat well. And this is how, this is the dry cine for it. And this is the aortogram, and which is fairly okay. I would say it has decreased quite a lot. And then we went to the left lateral view. This was a bit challenging. You could see how the wire crossed, and I'll show you how it crossed. Everything was done. This is again a view which shows you the degree of leak remaining after the first closure. And then we use TE for all the times. This is regarding the Rcc Pvl closure. Again, we took a 6 French system like 100 and then to 125 MPA inside this just to get support. And you can see the thermo wire, how it goes. It goes completely perpendicular to the valve. This is how the course was, and then it drops down. We were able to push the 5 French MPA somehow, but 5 French MPA, but 6 French guiding won't go in. So now the question was, let's choose for a device which is slightly smaller, and then I looked for Conar MFO, parked the Safari, and finally I was able to somehow push 6 French MPA. I was not able to push. I removed all the MPA system, and I tried going with some other catheters. Finally, a JR catheter went in, which was 6 French. Of course, I could close it with the AVP2 device, but since Conar was already open on the table, I tried doing it with Conar. And this is how the wire was removed, and this is JR guiding catheter, and now this is Conar MFO 5x3, which is the smallest size available, and is deployed. You can see the front, which is RCC PVL, the back is the Ncc Pvl, and you could see I injected, there was hardly any leak from the RCC side. Of course, this injection was slightly more and slightly more force, so there you see something. Device was released, nothing from the RCC, something from the Ncc, but I would rate it probably mild at most. And this was the cine in the RAO causal view for this patient. This is a tri-cine, and this is a aortogram which shows sort of trivial to mild PVL from the Ncc side. And the result angiogram, you already see both the views, and the pressures from diastolic pressures improved to 70. Echo, I have now good echo, but both of them were almost close. There was some leak and there was significant improvement in symptoms. Patient could walk half an hour on first follow-up after 10 days. Plan is to keep the patient as such and wait till she develops either symptoms or she deteriorates with LV dysfunction or PH part, and then to subject the patient to TAVR. Thank you.
Very well planned. That's an elaborate description. Quick comments?
Excellent planning, because as far as procedural details are concerned, most of us know as to how to go about.
How to plan.
Except that the RCS, not RCC, is not a cusp but sinus. RCS PVL was a little more treacherous, and direction was also more difficult, but fortunately it was small in size and required a small sheath. What about the hemoglobinuria? Because you left some residual leakage.
So
I think these patients should be very closely watched for hemoglobinuria rather than looking for hemolysis, because hemolysis may not be apparent otherwise.
So, in general, that's why we chose AVP2. This is the plug which is the softest and would lead to least of hemolysis. Of course, we all know that probably, it would be best that if we do leave no leak, but sometimes it is, the tract is so tortuous that probably you will have to accept. And it appears that it was through the device rather than through the tract. And I did the echo after 7-10 days and I could not find anything, and there was nothing. I did whole parameters for hemolysis and it was all good.
It would have also been good to slip in a catheter through the valve to look for the gradient. Now, what gradients now? Contribution of the PVL vis-a-vis the LCC immobility.
Yeah. So actually I looked at the gradients, and gradients were peak to peak of around 24. But once I had deployed the RCC, whatever you say, RCS or RCC device, then you lose the access to the LV, because your device is deployed and your catheter is higher up. So the only way to measure the gradients at last is to cross the valve, which I didn't want it to cross because it's a bioprosthetic valve and you would give more trauma to the valve itself. So I was happy with it. Maybe the peak to peak initially is 24, and echo-wise it came down to 20.
Dr. Anupam and Dr. Adi Yadav, comments, and Dr. Ritvik after that.
Okay,
So it's okay. I wanted to ask about the gradients, which is
All right,
discussed.
great. Ritvik?
We expect some fall in the gradients.
Yeah, the gradient fall by like 10 of mean, and the AR disappeared, and that's why the patient was symptomatic. We see many patients, the patient had a surgery and the mean gradient was 18. Now, if the gradient is around 25, I think she's going to do good. We don't want to treat everything at one go, because if this patient, I'm happy doing a TAVR, but the problem is you do TAVR and the same valve will also degenerate after 4 years. You have to drag it as much as possible till the right time comes and play the last card at the last moment. Don't use it.
Precisely, that is because deferring anything to be done at the aortic valve, I think that is a very wise decision, because even if you break the Magna 19 and you add up a couple of millimeters and you find PVL is extending till 6 millimeters, so that is not going to do. And the taste of the pudding is in front of us because the gradients have come down. So I think we can be happy with anticoagulants.
The only thing is that breaking, I consulted at least two people, one in US, Dr. Bapat and also Pradeep, and most of the people whom I consulted were very, very skeptical about valve fracture, because that is the other way to treat, and they were concerned about the aortic rupture, which would happen because we don't have any details about the patches. The pericardial patch would just go off, and maybe these leaks are from the side of that enlargement portion.
Two last comments.
The only difference is I will put the parabola leak on the bigger one with those who contain fibers, like LifeTech device, Sera device, has fiber, or you can use even the bigger one, your conar device, which contain fiber more
So-
than 9 millimeter,
Yeah,
9 millimeter above.
So-
And for the right, I could have used ADO2, which goes with the 4 French or 5, even 5 French guide.
Yeah, so
That is the difference.
I agree with you, but I would differ with two things. One is regarding the Sera plug. It is a single plug. It doesn't have waist. It doesn't have 3 discs. So it
No,
doesn't.
there is no need of here 3
No,
discs.
there is.
You
it
need
doesn't give you-
oversizing, and that will close with the because of the fiber.
It would close, but it don't remain stable, sir. And it has very little experience with Sera plug, which is at this position. I have not seen people using it. Second is regarding using the Conar FFO. I have used it, but the only thing is we need to understand that these devices are slightly stiffer. And if there is mildest of hemolysis, mildest of leak, it would lead to more hemolysis. And that's
No,
why
ADO2 is very soft device, very
soft-
good device for this.
Yeah.
It comes up to 6 millimeter,
Yeah.
6 by 6. So above that you can use Conar because Conar above if you want with fiber, or you can use the LifeTech device.
Thank you
with the
very much.
the
fiber.
only idea is
I
like
think we'll have
AVP is
to-
the softest one with least of hemolysis, and that's the most important concern post procedure.
Right.
Thank you, Manik. It was
I
a
think
great
we'll
case.
end this discussion here because we have one more presentation. Dr. Hazra is here with us to show his complication, which he bravely addressed.
Yeah, thank you very much for the last remaining audience, like last remaining coronary
This
arteries.
quite
Yeah, but thank you very much. And one thing I have learned today and missed today is the participation and asking a question asked from the back rows rather than front row asking questions. So you should always have such kind of beautiful program, small program, and it's quite absorbing. I tell you, I have spent almost 2 days. I never spent so much of time because it was so absorbing, pleasurable, and participating, and regards to my seniors and Dr. Atul Mathur. And I'm sure my presentation would be that impressive. The first, a declaration of disinterest. I have produced perforation in the past, and you will also produce perforation in the future. I have lost 4 patients, and my patient will be one of them. And some examples are here, not mine. And you know, CAD plugs not always simple like pimple. It may be soft, it may be very hard. And how many people will remember Dr. Martin, who was the second person on this world to do angioplasty in human being after Grunzi? So he thought that these plugs are so soft, like a footprint on your snow, and sometimes it can come as a surprise, it's very hard rock behind. So what are the words of wisdom before commencing my talk? Good judgment comes from experience, and experience comes from bad judgment. You can watch that movie and the message from the movie. Now, it can be torrentials, it can be sprawling, it could be dissections and perforations, it could be seen during surgery. They may not see any perforation during surgery, still people can die. And sometimes it is ugly to look at, but forgiving because it is draining either in the large vein or in the large chamber. It can be seen after cutting balloon, it can be seen after putting a covered stent, and it can be a 2 covered stent story, still it will be leaking. So if you have this kind of leaking graft, actually your time is running out, and you should also be prepared to call your friend to be in help to put a pigtail in your pericardium. So this torrential thing is important, and this can be a disaster kind of complications, especially in post-CABG patients. So this hematoma, which forms behind the left atrium, can compress the coronary sinus, can cause ventricular tachycardia, not because of your coronary. So retroperfusion is hampered, so there is relative ischemia. It can cause a mitral stenosis-like thing. So these are the usual things should be avoided at any cost, and these should not be neglected. Now, it can be voluminous. It can be due to your small OCT catheter, which gets kinked, IVUS catheter, which gets kinked. So you should put this device with a lot of care. So kink device, once you see this kind of perforation, there are many options. You know, the fat, sandwich technique, handmade sandwich. You can just
inject a cut balloon, half cut balloon in the coronary, and always think outside the box. Fool me once, shame on you. Fool me twice, shame on myself. So we learn from mistakes, and we always on the hindsight get wiser and wiser. 2021, still Japanese, they use DCA for left main. And these Japanese cuts are much bigger cuts than the rest of the world does, because 2008, the DCA was banned. So these cuts are sometimes very devastating, and you have to be very, very quick in putting this thing in your coronary pericardium. So sometimes action is needed, sometimes inaction is also of help in some of the perforations. But you need to have those kind of quick skill and know your gadgets. So here is a man, and a 60-year male smoker, ACS background, government scheme patients. You know, the government scheme patients, we have some restrictions, but human life is definitely precious. Stent 3.5, cakewalk, pre-dilatations, and after that, I'm not able to push any other gadgets like new balloon, small balloon, because of some kind of malalignment in the left main. And we thought the stent would have been much longer so that it could have had alignment. So there was continuous deformation of the stent, and there was LSD, which is not discernible here nicely, but on real life, it was actually seen. And ultimately, that led to an first catastrophe, that the flow was slowing down, and I was working on cangrelor, argotraben. You can blame ACT. ACT was 500 plus. So first we gave intracoronary adrenaline, which is very, very useful, very quick, raise the blood pressure, raise the motion of the heart, and you escape the first catastrophe. Now, you know, when you use this Oxford, if you use opium balloon, sometimes this indeflator, deflator, they get jammed. So my operator, second operator, actually inflating the indeflator, suddenly I saw it has reached 55, from 0 to 55, and boom. I mean, this can happen with special indeflator, which comes with your opium balloon, new one. So what I do nowadays, go to 4 or 5 atmosphere, then come negative, then slowly this Oxford indeflator, which comes with opium balloon, can cause this kind of devastation. This is second time it happened in my life. So what do? You have left main, you have circumflex. So whether you go for a double barrel stent gap, and immediately this patient crashed, you know, because of the large effusion. Obviously the pigtail was in, and you planned about a graft master. Now I did not have much time to put 2 guiding catheter, 2 barrel in the one in the circumflex. So I was thinking, I've seen some people in Europe, they have done fenestration of the graft, and I was ready with the angle microcatheter, the miracle wire, etc. But time was running out, you know, the still leak, and the CPR started. So I called the ECMO guy, and ECMO guy, you know, in best hospital, even in US, takes some time to arrange. But because of the circumflex chopping off, I thought he will tolerate the lateral wall MI, but he was not tolerating, was not doing well. Adrenaline, massage, SKS graft, ECMO, etc. Call a surgeon, but all these running out of time, and I was puzzled what to do. And this continues, arrest, EMD, and that's the end of the story. But what I have learned, I learned from my previous, that if you really want to do a pericardial puncture, the EP guy, they always go lateral. Dr. Trehan is a master of perforations. Initially, he entered the RV, then pulmonary artery. So always go to the lateral, take a small amount of dye in 5 cc syringe, keep a track. So this Trump track or the lighthouse will show that you have entered. First time, because of the obesity, the needle came out, but later on, I was in. This is continuing. So this is one, this is a rota, this perforation you always face. And as I said, IVL is the king of the corners, queen of the tortuosity, and queen of the ostia. So orbital and rota infinitely is required in some cases, what Dr. Bali was showing, but these are the usual mechanism, broken web, and this can happen. So calcified right coronary artery, it was not in hypotension, but there's a lot of apprehension what will happen at the middle of the night. So these people can crash later on. So better to be on the safe side, and we put a gram master. This leak was persistent, sealed off. So easy peasy case and good outcome, happy ending. Sometimes masterly inactions. This case I posted in Twitter, and this I observed for half an hour. No pericardial effusion, no hypotension. Confidently walked out without anything. So, ladies and gentlemen, in retrospect, everybody becomes wiser. Every tricky cardiologists have third eye on their back, but many of us do not have. But always can take help from master and previous experience. So, imaging and judgment of the respect to the coronary. I said it before. I'll say it again. And the last word: never let your success go to your head, and never let your failures go to your heart. Thank you very much.
Experts.
I think it's a big topic, very nicely covered. Thank you very much.
Dr. Claire is making a comment. I saw you getting up. So this has been a wonderful 2 days of interaction. But you have to praise the operator at least. He's done such tremendous
that
work.
That patient where you put the left main covered stent,
yes.
So did you cross into the circumflex?
No, sir, it was crossover. It was a crossover because the time was right. This was torrential flow.
Left main to LAD.
Left main to LAD.
So Circ had to be sacrificed.
With the steeper.
I had a similar case, very recently. So I stented from left main to LAD, lot of VD, cardiac arrest, blah blah. But she survived the initial catastrophe. But in the then CCU, sepsis and that cascade, ultimately we lost her. So
yeah, so you have to survive the initial storm. There are a lot of things happen at that time, right. And after that you have time to plan out and think. So very well handled. Very well handled.
But I did not get time.
So yeah, if there is a significant branch, I think it is a good practice to leave a wire and a balloon outside your stent graft. Deliver the stent graft. Then let the thing settle down.
Keep leaking.
Once they settle down, then you blow up the side branch and pull out your balloon and see what is happening. Many times you will find that you will have access to the side branch, and once you're seeing the side branch, then of course you can use one of the super crosses or maybe any other and puncture, because the graft master is still little difficult to puncture, yes, but yeah, PK Papyrus can be rather easily punctured with any of these. If you have a stator 20, it can easily go through that. And if you have already blown up that part with a balloon already packed into it, and your vessel is flowing, you have a good landmark with a wire also inside. Right. So it's not a bad practice to leave, because a lot of people will leave a wire into the side branch while they are putting a stent. Why not leave a wire and a balloon into the side branch once you are putting a graft? Like that, because you can easily remove that.
Last comment.
Why not wire both circumflex and LADs and just take two covered stent and just...
No, there will always be a leak from
that. Barrel have also been used, but often if you have a left dominant system, then of course you're left with nothing. You create a double barrel SKS with these covered grafts. But if the circumflex is not that big, or a side branch for that matter, diagonal is not that big, then just to leave a wire and a balloon and test it a little while after that. But remember one thing, that your anticoagulation should be up while you have any gears inside the coronary arteries.
Thank you very much. Thank you. So we close this session, but before that, I really want to thank all of you, because now we are at the end of this this meeting after such a long COVID break. So it's very important that I appreciate that you people have traveled from far off places, from Delhi, spared your time. There was so much more you could have done on a weekend, but you have shared your knowledge and skills with each other, and I'm sure everyone goes as a winner from this. We'll also have to thank the people who were behind this. And first of all, my thanks go to Priya Babbar, who I think mostly she has interacted with all of you. She has been the real hand behind the organization of this meeting smoothly. Also my team in my office, Vibhuti Sharma, Reena Koirala, and Amit Khetri. So a big hand for all of them. Thank you very much. And of course the industry, they always keep supporting us for such interesting ventures. See you again next year, friends. Bye-bye, all of you. Thank you.